All right, welcome everybody to Optometry Education Consultants National Webinar Series, Sunday night edition. Topic is Glaucoma and Co Management Reimbursement The Right Way with Dr. Joe DeLoach. He's the CEO of Practice Compliance Solution. Dr. DeLoach's career includes private practice, medical director for 20 years at one of the nation's largest optometric referral centers, and former clinical professor at University of Houston's College of Optometry, where he was director for medical eye care services at multiple inner-city clinics providing care to over 8,000 indigent patients per year. The clinic served as training sites for almost 1,000 optometry externs and 30 ocular disease residents. He is a notable lecturer on ocular disease, billing and coding, and healthcare compliance, having presented over 3,000 hours in education. He's a member of the Optometric Glaucoma Society and co-developer of the Glaucoma Professional Series at University of Houston's College of Optometry. He has received every award given to a Texas optometry, including the coveted Distinguished Service Award, Armistead Teaching Award, and TOA Educator of the Year. Dr. DeLoach is president and CEO of Practice Compliance Solution, a company providing medical compliance, insurance billing, record audits, clinical education, and practice management services. So please give a nice, warm, virtual welcome to Dr. Joe DeLoach as he leads us to the next hour and 40 minutes, Glaucoma and Co Management, doing it the right way. So Joe, please take it away.
Thanks, Joe. Well, I'm really tickled to be on this. I'm glad that I'm talking about coding for glaucoma, because I'd be up against Joe talking about clinical glaucoma, and I don't know. You know, he's one of the people I really respect in the glaucoma field. Very knowledgeable. So we don't have to compete with that in this lecture. We're just going to talk about the way to get properly paid for the things that we do. So we'll get right on with it. I have no financial disclosures related to this presentation, so we can skip over that. So this is what we're going to try to accomplish in a very short period of time. A little bit of the landscape of healthcare, a little bit of what medical reimbursement is really all about, and then we'll get down to the nitty-gritty of glaucoma, and we're going to go through everything test by test. So we'll get there. And then the second part, seemingly unattached part of this presentation, we jump ship and talk about the world of inducement. It's an interesting mix that they've asked for, both very relevant right now, but seemingly disjointed. But we'll put them all together. So, I mean, bottom line is we're looking at a very unhealthy healthcare reimbursement system. Lots of fraud, lots of abuse, lots of bad things going on, and these numbers are pretty staggering. So you see the quote at the bottom. I mean, someone takes $290 billion away from you. What are you going to do? And I think, you know, everybody's going to go after the money, and that's really what's going on right now. So the government wants that money back. Laws really haven't changed here. Most of these reimbursement principles, as we'll talk about them, are nothing new. It's just they're going to be enforced in a stronger and stronger way because of the fact that we have a very abusive and fraudulent system going on. Now, as physicians, as doctors, we are charged by the fraud and abuse laws to know what we're supposed to do. So ignorance is no excuse. That language was changed a long time ago. So we are obligated to know how to do things the right way. So there's three big things that have happened recently that kind of changed the whole landscape here. And one was called the Whistleblower Act. And, you know, we have all these rules and regulations and things, and the government really doesn't have the manpower to go seek and destroy. So what they did was quite genius. They decided to train the public. And for those public people who will kind of narc on their doctors, they get paid a handsome fee for that. The best example of this is actually right out of Medicare. It's called the Medicare Senior Patrol. And we actually are training, or CMS is actually training your patients basically to spy on you. So, I mean, it's remarkable how they have found a way to enforce these regulations. Now, the other thing that's going on is the old days of sitting down with a piece of paper and auditing that piece of paper. Everything's going to be done by what's the system called predictive analysis. It's computer algorithm. And so computers will be judging the likelihood based on the documentation and billing patterns that what you are asking to be paid for is actually legitimate. And instead of what we used to call pay and chase, we'll go audit, say it wasn't legitimate and ask for the money back. The money is withholded until you can actually prove that it is legitimate. So big change in things going on. They're really going after fraud in a huge way. You would wonder why we have such an issue with outright fraud in medical reimbursement. Part of that is because some people just don't know how to follow the law. And part of it is physicians are doing things fraudulently and don't even realize that that's what it is. We'll cover a little bit of that. So like I said, we used to have what we call the post-payment or pay and chase audits. Those are all going away to this new system of AI, basically the computer assisted analysis of the way in which you bill. So what's the best defense against this? Well, a great offense. That's pretty much it from the beginning. It's really about just being an ethical doctor. If we always just put our patients first, billing and coding really is not that complicated, but it does require that you have exquisite medical records, and that requirement is going to be much more important with these new AI predictive analysis systems going. Now, there's a lot of rules. I don't really talk about rules much when we talk about billing and coding, because I like to talk about the principles. And if we really understand the principles of reimbursement, the rules usually fall into place. Now, I would encourage you, another reason we're getting a lot of abuse and fraud is because we have a lot of people basically spreading incorrect information. So listen to the experts in our field, and I beg you, please watch very carefully, following advice on blogs, especially billing blogs. They've become probably one of the #1 sources of incorrect, if not fraudulent, information in billing. Then you can also do training audits. Those are offered by many companies where you kind of get an idea of how you're doing before the real people come in and ask to have some of the money back. Now, optometry a problem? Absolutely. As little as 6 years ago, we were considered the 10th most fraudulent and abusive billing specialty. We got a little better. We're still in the top 3rd, but that's really not acceptable or a badge of honor for our profession. So, the question comes up, why does the robber rob the bank? Why do we look at certain groups? Because that's where the bad things are happening, and that's where the money is to take back. So just because optometry is a small profession and a small part of the kind of healthcare budget out there, don't be fooled into thinking they're not looking at us, because they are in a major way. So where'd we learn this to do things the wrong way? Part of it, Joe's been involved in academia forever. I was for a long time. I don't think we probably do as good a job of teaching, medical reimbursement principles in our upbringing as we possibly could. So we start off on a little bit behind. And then there's these experts out there. And as I already alluded to, a lot of them are basically their expert advice is do it this way because I'm getting paid, which are probably the most awful words a auditor would ever want to hear is, why did you do this? Because I've been getting paid for doing this. That doesn't mean it's the right way. So you can see kind of at the bottom, these were some audits that are in the last couple of years, and these are optometrists, and these are the figures they paid back for their audit. So that one at the end is pretty staggering, $3.2 million. That was a single doctor, single location office, and you have to run those numbers in your head to figure out how that could even happen. And of course, what you'll find out is it can't happen, which is exactly why the massive takedown occurred. So as I said, a lot of this comes from because people just out there trying to figure out ways around the system. And the more you try to figure out ways around the system, the more you're going to get stung, because just figuring out a way to get paid doesn't mean it's the right way to do it. So like I said, training audits, thousands of encounters. We're running about a 29% denial rate. So in our audits that we do, we find about 29% of it you get to pay back. Of course, that's a mock audit, and we can blow that up to a 5-year back penalty. The numbers can get pretty staggering. Again, this is all a mock situation, but it's certainly not what you would want to face in a real Medicare audit. So what are the main things that we're doing for this reputation? And all of this is going to play directly into glaucoma. Well, number one is these are the principles I keep talking about all the time, not so much coding rules and medical directives, but what are the basic principles? And there's really two of them. And if you really get a grasp on reason for the visit and medical necessity, you have 80–90% of all billing and coding down pat. Reason for the visit is not understood well in optometry. It basically says the only care you can deliver to a patient is the care that addresses the reason they came in to see you. So if they come in and say, my eyelid itches, that's your job, not to evaluate them for brain tumor and glaucoma and, you know, binocular dysfunctions. It's like your job is to address why their eyelid itches. Doesn't mean those other things aren't important, means likely you would do that at a different visit, but our main job is to address the reason for the visit. And this is the number one reason that we are being significantly audited regarding the ophthalmological codes, which I'll show you in a minute. And then medical necessity is really easy. It's like, does my patient really need this? Do I need this information to properly take care of my patient? If the answer is yes, we have defined medical necessity. And by law, actually, only you as the attending physician can define what's medically necessary for your patient. Don't confuse that with what your insurance is what their insurance is gonna pay you for. That is not medical necessity. That is a payment decision or a payment directive. They can decide to pay or not pay for whatever they want to. Doesn't mean it wasn't medically necessary, but when you define care as medically necessary, someone has to pay for that. And if it's not part of their insurance benefits, patients get to pay for this. This is common knowledge, common practice in the medical community, and something that we have to accept as well. As I said, this is the problem we're seeing with the ophthalmological codes, especially the comprehensive ophthalmological code. As a Medicare auditor, I can tell you can't throw tomatoes at me virtually, but as an auditor, I can tell you that we have metrics that we go by, and the general average we're looking for in your total submissions is about 52%. And optometry average is well above that. It's come down a little bit over the past couple of years. Maybe somebody's listening to some of us, but it's still way out of line. And it's again, because when we see that patient with an itchy eyelid, we think that is a comprehensive evaluation of the eye, and it absolutely is not. This is actually what's going on. CMS has a standalone auditor, the RELI group, who is out auditing our profession. And some of you may have received a letter that looks something like this, that gives you your percentage compared to their metrics and your colleagues or your peers' averages. And this is like a warning shot. You know, this is like going, you're doing something out of line. You need to figure out why your numbers are out of line with what we're expecting. Part of that as well will give you a number called the average per patient or average per claim revenue. And what I put up in the screen was actually from 18, but that's per patient. So if you took all of your Medicare reimbursement for a year and divided by the number of office visits, not number of patients, but number of office visits, you will come up with a number. And that's our number. Now I'm going to contend that number is way low. And I'll show you a kind of an interesting graph on optometric billing in a minute, because what it's going to show, and you probably already know this, we have a lot of people way under billing, a small segment that seem to kind of have things down in a right way, and then a little tip on the other end of the scale of folks that are way over billing. So that's where we get this number that I think is probably than what we would want it to be. So you can figure out that number for yourself and actually do a little comparison. Now, there may be reasons that your number's higher or lower. You may have more or less medical patients, but you may be doing things the wrong way. We're going to talk about bulk or panel testing in a second here. That's a big problem in optometry. Or you may just be flat over testing. So you have to watch these numbers, because that's really one of the major metrics that they're looking at when they say, who are we going to go look at from a focused audit standpoint? Here's that graph I was telling you about. You see on the left end, we have a lot of people just not doing a lot of stuff. And that hurts our profession. We have a lot of our colleagues who will see a glaucoma suspect or a glaucoma patient, maybe do an office visit and say, I just don't want to deal with this. I'm not going to run any tests. I'm going to refer this out. Fortunately, most of those referrals go to general ophthalmology. So their value, it significantly drops our per encounter number down. Then we got some in the middle that I think are probably the best representation where we'd be. And then that big spike on the right side is a problem. So where is the problem? It's at both ends, both hurting our profession in different ways. So let's talk about excessive testing just a little bit. A couple of things just to make you think a little bit. It's estimated that we're doing about $250 billion of unnecessary testing in the entire medical world per year. That's a big number as well. I love this Dr. Brawley, who said, he used to be the president or the past director of the American Cancer Society. And when he talked about a actual screening colonoscopy versus some of the other options, he said, everybody's getting the colonoscopy. And you see the reasons he quoted there. I mean, it's like no one's going to get paid for it and no one wants to handle, so that's not the reason we should be selecting tests. We should be selecting tests based on what's best for the patient at the most reasonable cost. And then, like I said, closer to home, since we're talking about glaucoma, we have a barrage of technology in glaucoma that I contend is helping us do a better job, I suppose, of managing this disease, although we really haven't seen hardly any downturn in the loss of vision associated with glaucoma. So that's a whole nother lecture, but point is a bunch of extra testing is not particularly helping our glaucoma patients. Now, here we go. Joe, you're costing me money. I'm already getting not interested in this lecture because all I'm hearing is I'm doing too much. You want me to do less. That means I make less money. And I'm going to contend that that is absolutely not correct. If you simply do things the right way and every decision is based on what does my patient need, I contend your revenue will go up far more than trying to manipulate the system by finding ways to quote unquote get paid. So this is what we call, this is kind of one of the grandfather laws of diagnostic testing that everyone needs to understand. It's called the confirmatory testing rule. So this is right out of the Medicare claims processing manual. And I can translate it by, an old adage of, once you hit oil, you stop digging. And that's really what the confirmatory testing law says. It says, once you know the answer or reasonably sure of the answer, your job is done and you can't keep running a bunch of other tests to confirm basically what you already know. Now, that doesn't mean that you can't run additional tests, as we'll find out later. It just means in general, a lot of times we know the answer, and when we know the answer, we put the shovel up. And that's pretty much what it comes down to. For a diagnostic test to be paid, and I think it's the next slide, we'll come to it in a minute. So this confirmatory testing is all about these panels that we see. So when we visit offices, we see these stuck up on the wall a lot. It's like for directions to my technician, if a patient comes in and they have a history of glaucoma, we automatically run this series of tests. Well, basically that is fraud because you can't do that. Every time you make a decision to run a test, it must be based on the knowledge that you have going into making that decision. So you run tests, you have information. Do you have all the information you need? Yes or no? No, I do not. I may now go get more information. Do I have the information I need? Yes, I do. We're done. So we can't just arbitrarily run a series of tests as our protocol for glaucoma or AMD or diabetes or any other test you want to throw up there. I don't do it that way, though. I do a lot less than that, and I don't do it as often. Well, this panel still breaks the confirmatory testing rule because you're still doing things as a group without individually addressing the medical necessity of each individual test. So let's do less. Well, we're still breaking rules. So I cannot order a fundus photo for a glaucoma patient. And we'll talk more about in a minute. I want that to roll around in your head a little bit, but you can't decide in 6 months you're going to take a picture of an optic nerve in a glaucoma patient, but we'll get to that in a minute. So how will our testing survive? So this really is right out of CMS. And if you just go through this in your head, when you're trying to decide to run a particular test, you can almost invariably come up with whether or not you're going to get paid when someone comes looking for the money. So is it related to the reason for the visit? Well, in our glaucoma world that we're going to be talking about, the reason for the visit has to be related to glaucoma. So in the initial evaluation of a patient we've never seen, that's going to be quite limiting, and we'll talk about that in a minute. But once we have established they have glaucoma or a suspect for glaucoma, we're in the driver's seat now, because I can now say when they come back the magic words that auditors want to see, which is, this is a physician-directed evaluation of glaucoma suspect, moderate glaucoma, or whatever it is. And I can even order testing associated with that. So this is a physician-directed evaluation of a glaucoma suspect, and I am ordering a 24-2 OU and a OCT of the optic nerve. That is beautiful documentation of a reason for the visit. Auditors will smile. You want auditors to smile. When they see that kind of documentation, they know you know what you're talking about. The next thing is the data usable. So never put in your record, and this is visual fields, and we know sometimes we'd like to take our visual field machine and put it in the dumpster, but you cannot put down that the testing results were garbage, because by definition, it can't be medically necessary unless it gives you information that you can use to take care of your patient. So if you document in there that you ran visual fields are totally unreliable, can't do a thing with them, then actually you shouldn't be paid for that test. Now, we know that a chunk of our visual fields are not reliable, so just watch your wording. It's very uncommon for them to be totally unreliable. So you can put questionable reliability. You can put, 50% related. Come up with something, but don't make the statements that make an auditor think the data was of no use whatsoever.
Joe,
Yes.
Joe, if I could, in terms of glaucoma, we've actually gone away from the yes or no, reliable or unreliable. Our terminology we kind of use, and this is subjective. High degree of useful information, some useful information, low degree of useful information, or no useful information at all. So that is very good terminology to use. That's what we're using in glaucoma. Is it highly usable? Is it usable? Is it minimally usable information?
Yeah, and the only one you don't want to put down is not usable at all.
Right.
Because even low amount of usability gives you some degree of information, but it's that last one that's going to sting you.
Exactly.
All right, how does it contribute to the care of the patient? That is basically the definition of medical necessity. When we talk about interpretation of reports, you need to state how you're going to use this information to take care of your patient. This tells me that they're stable, and I'm going to repeat my evaluation in 6 months, or I will conduct another OCT or whatever. But you just have to put down how this is directing the care of the patient. We have to know that this is not confirmatory. So did it stand alone in its medical necessity? Now, the less expensive test really doesn't apply to us so much. Was the test ordered? That's a necessity. Do I have an interpretation and report? That's a necessity. And then last on the list is, do I have a payment policy? Now, sometimes you do and sometimes you don't. If you do, it's a very good idea to follow that. But if you don't, all these other principles still have to apply, because if you decided to run it, by definition, you said it was medically necessary, therefore someone has to pay for it. And in this case, it's going to be the patient. So not that hard. Is it medically necessary? Not confirmatory, in line with policies, and did I document everything correctly? It's really not that difficult to do things the right way. So this is one that always comes up, the OCT and fundus photo at the same time. And, you know, I can just tell you over and over and over, this is the kind of stuff we see on the blogs. It's like, you know, coding people are not trying to not make money or telling you how to not make money. They're trying to tell you how to make money the right way. And these kind of comments really have no place. So the 59 modifier is still absolutely the most audited modifier in all of healthcare because it doesn't have very many applications at all. And when we look at payment directives, glaucoma is never an exception to the 59 modifier for OCT and fundus photos performed on the same day. Now, to be honest with you, I don't see why so many people want to cram them together. Glaucoma patients you're going to see many times over and over, and you have plenty of time to run these tests on different days. Don't need to cram them on the same day. They have now, for this is a national edit, which means you can't do it unless you break the edit. And it's been stated that the 59 modifier is not appropriate to break this edit. So there you go. I don't know what else to say. Just don't do it. So that's kind of what happens when, from a Medicare auditor standpoint, when that 59 modifier pops up, it's like, please come look at, put a big sign in front of your office that says, please come audit me, because it will definitely not withstand audit. Interpretation reports, they're required. I think they're silly. They come from a day prior to kind of all of our electronic monitor or electronic recording, where, you know, when I was out of school years and years and years ago, we didn't even have electronic medical records. You had to write everything down. And that's where interpretation reports came from, is writing down the results. Now everything's saved digitally. Interpretation reports really make no sense, but it's a lingering concept that is still the rule, and you have to do it. I've never found specific direction on what to put in an interpretation report. I can tell you in audit circles, these are the kinds of things they're looking for. And those are the three biggies. Why did I run the test? What did I find? And how am I going to use it to help my patient? But that is literally defining medical necessity.
Joe, before you go further, if you don't mind, a good question came into the chat.
Yeah.
You may be covering this shortly, but what about two different diagnoses on the same day? OCT for macular disease and disc fundus photo for glaucoma.
Yeah. So the edit makes no distinction for different diagnoses. It purely says these two are not appropriate on the same day. So I've seen that one before too. I can tell you in an audit that will be denied as well. There are limited exceptions to the 59 audit, and none of them apply to glaucoma. They will apply to macular degeneration in some cases, but that's not the topic tonight. Okay. We don't need to talk about orders other than make sure you have them. So that's the backbone. That's the backbone of, you know, what we need to do to go into now test by test. What are we going to be doing for our glaucoma patients? Joe, did we have a polling question there?
I need a polling question. I can put one up for you.
I think we had two. Here we go. So great advice on staying correct. Legal reimbursement is have your records audited. Yeah. Know which regional payer rules. Yeah. Listen to coding advice on social media loops. That would be the one I would not pay attention to. So that's going to be my answer for sure. And I think we can pull that second polling question up too.
I'm not going to go for just a second. Remember, this would include all but which of the following. Okay, we got a pretty pretty good response here, and I think that Joe, you got your point across. You don't really listen to the social media blogs. Those aren't very helpful. So stop sharing. You say you want poll number 2? We'll launch that right now.
Okay, biggest concerns in audits include over and underestimation of proper evaluation management service code levels, use of panel protocols, poor understanding of the core reimbursement concept or reason for the visit, lack of fundus interpretation reports and orders, or all of those seem to be somewhat of a problem with at least some people.
We'll give them a second to record their answer. I'm looking at the chat, and it looks like we're all caught up. I did launch the handout a short time ago, so it is in the chat room if you need it. Okay, we've got a very active group here. We're already up to about 80%. So I am going to end the poll and share the results. And Joe, why don't you discuss the results?
Yeah, I think everyone got that one real well. I mean, all of those are things that we're seeing as problems, at least with some people, both on the undervaluation of what we do and the overvaluation of what we do. So I'm glad I got that one across well. Okay, so let's talk about glaucoma. Now I kind of went through and I'm just throwing up every single thing I can possibly think of.
Hey, Ziggy boy.
I'll find them.
That would be a suspect for someone for glaucoma. And just understand that some things just by themselves are weak as far as establishing medical necessity. So just, I've literally seen, it's like, I audited one practice, and the average patient age for this particular practitioner was 73. And they considered that to mean that every one of their patients was a glaucoma suspect based on age. Again, some of these things have to have more behind them to really justify that they are a true glaucoma suspect. A lot of other ones that I see, just buzzwords that'll get denied. Optic or glaucoma suspect based on cupping, which is a totally ambiguous, means nothing word. It's like, unless you have a hypoplastic disc, every single person in the world has cupping. So you have to have more than just cupping to justify what's going on there. So, this is more of a clinical presentation. I won't go into each one, but make sure you have enough things down that really justify jumping off the glaucoma cliff and going after it. All right, so what are the big hits? So if I rely a lot on two sources of information. I rely a lot on the preferred practice patterns, the American Academy of Ophthalmology, and I rely a lot on the World Glaucoma Association's kind of statements and experts they have there. And, as much as we know and don't know about glaucoma, the big hits are still there. And number one is still basically what's going on with the donut. And so we always we don't want to underestimate the importance of a not only objective, but subjective analysis of the optic nerve, because that's really where it all starts. Now, we're learning a lot about low tension glaucoma. I don't think that's a good term for it. I don't think normal tension glaucoma is a good term for it. I'm not sure we have a good term for it. It may not even be glaucoma. Some people are thinking not. Maybe purely a vascular disorder. Some people are thinking so. There's some new information that kind of supports that. But nonetheless, they do kind of have different presentations to some degree but it's still going back to the donut as being the most important factor that we're evaluating. Now, when I said some new information is coming out, Dr. Louis Pasquale just released some, or I don't know if he's actually published it yet or not, getting ready to if he hadn't published it already, where he's actually looking for biomarkers for glaucoma, just like elevated blood glucose is a biomarker for diabetes. He's looking at, are there actually biomarkers in our blood chemistry that say you are at risk for glaucoma? And what did he find? He found, and very predominantly in the low tension glaucoma category, it's all about things that make us fat and obese. And so there's a big kind of shift in ideas that, I mean, shoot, that someday we might be looking at our low tension glaucoma patient and running blood work instead of a visual field. It might give us more information. It certainly may direct us toward treatment that may be more effective than what we've been doing for the last 100 years or so. So why worry, test away? Well, testing really can give you a totally negative profile. Many payors are looking at your reimbursement numbers as part of the decision whether you get to be on the panel or not. And this is where that graph bothers me, because I'm getting compared to people that are literally not managing glaucoma at all. And that's really not fair. And just another reason we really want to elevate our profession to a, you know, really managing disease at a very, very high level. Okay, so let's get to the tests. Why I thought of every one I might think of. So we're going to kind of go through this list, and I'll tell you, you know, what do we know from a payment directive standpoint? What does the preferred practice patterns tell us? And I think I say it later, but you may be wondering, why do I rely more on the preferred practice patterns than the American Optometric Association clinical guidelines? And the reason for that is not that I think ophthalmology is smarter by any level, I actually don't, but their stuff is way more current. So the AOA is trying to fix that right now, and they're trying to get all these clinical guidelines more up to date based on what we know. But until such time, I'm still going to rely on the more current information that's out there. So, like I said, this is kind of where we're going with it. So let's start with intraocular pressure. Well, it's not a billable test, kind of. There are two exceptions to that, one being serial tonometry and one being corneal hysteresis. Serial tonometry is it's in that graph of, you know, the billing patterns. No one's doing it at the bottom end. Very few people are doing it in the middle, and tons of people are doing it on that big spike on the right side. Be very, very careful with serial tonometry. You know, I've heard, you know, it just means you had to take their pressure twice and document it. And that is not what it means. There are very, very limiting guidelines on when serial tonometry is applicable as a test for glaucoma. It does have its application, but you see it's mainly like when you have uncontrolled or some suspicious narrow angle things going on. Unfortunately or fortunately, it reimburses at a pretty high level. Now that, I hate to be sinister or accusatory, but that tends to be one of the factors that drives overutilization. And I'll tell you two reimbursement stories about that a little bit later. But be very careful with serial tonometry. It requires a large amount of documentation to justify this. It's not just running tonometry a couple of times. Now, corneal hysteresis is a billable code. Now, unfortunately, there are few payors that are recognizing it as something they will pay for. Again, don't confuse that with not medically necessary, because there's a huge amount of body of science that feels that corneal hysteresis is very dramatically important in the disease of glaucoma. There are people on the other side that feel there are not. You know, in science today, one of the unfortunate, I think, things that we see is you can prove about any point you want, because there's somebody on one side of the fence and somebody on the other side of the fence that will give you just as much information to prove their side of their way of thinking. So you kind of ultimately have to decide for yourself in many cases what's going on out there. I can tell you, I know many glaucoma specialists in Texas that rely heavily on corneal hysteresis as a factor. Again, most Medicare carriers do not pay for it. Some medical payers do, but you'll hear me say over and over, just decide what your patient needs based on your understanding of these tests. And if you feel this is something you need to take care of them, then by golly, you've defined medical necessity and you should do the test. And you know, when patients go to their MD, when they get to checkout, it is no surprise to them whatsoever to hear, I need $407 from you today for the things your insurance did not cover. And that's true in our world as well. We just have to get to that point where we're comfortable with that. And, you know, there's no reason not to be. So you can get paid for it by insurance in cases. You can always have the patient pay for it. It is not a high reimbursing test. Certainly if you were doing it, your usual and customary would be whatever you feel would be appropriate for that test. I am showing fees in this presentation. In no way do they represent what I or anyone thinks you should charge for anything. These are actual, just their average reimbursements according to Medicare across several carrier platforms, that you would always determine what your fee would be. Glaucoma world, as I said, is sharply divided on hysteresis. Some feel it's literally the most important thing out there, and some feel it's of no value whatsoever. Again, you have to research and decide and do some reading and study for yourself to see where it applies for you. Optometry. Well, this one's interesting. This is a radiology code. It's a bilateral test, which means when you bill for it, they are assuming that you did it on both eyes. And actually, if you did not, you're supposed to tell them that, and you only get paid for one eye, which should be 50% of the reimbursement. Everything requires an interpretation and report. There is a carrier directive for this, and so that's National Glaucoma or National Government Services. That may be some of you on the webinar's Medicare carrier. The reason I'm listing, you know, carriers all over the country is because a little bit of an unknown rule is that when the carrier that you are under does not have a medical policy on a particular procedure, they have the authority to use any other carrier's policy. So if a policy exists anywhere in the US, it's advisable to know what that is, because that's the one you could be judged by. So there says that we will only consider this as medically necessary for pre-treatment of primary open-angle glaucoma. Now, that makes sense because the concept of it being a risk factor for glaucoma came from the OAT study, which only evaluated ocular hypertensives. So science doesn't let us go beyond what the study found. And that's literally what the payor did. It's a one time in the lifetime of the patient, unless something significantly clinically happens that would potentially change that finding. You see, you don't get paid much for this test. The other thing that I want you to know is, by definition in the CPT code, you cannot substitute a anterior segment OCT and bill for pachymetry, because pachymetry is specifically listed as a ultrasound test. Now, doesn't mean that test is not valuable, although I would contend somewhat questionable validity. I mean, the fact that the angle is 39.3 degrees open is not earth-shattering to me at all. I think it has great application in angle anomalies, especially in Asian populations that are walking around with literally chronic narrow angle glaucoma, that their angle looks wide open. And even under ganioscopy, unless you are really, really good with a gonio lens, they still look to be open. But the anterior segment OCT can show you that very bizarre angle that actually is more closed than it is open by closer evaluation.
Before you go on about pachymetry, as you say, and I think this is, it might be fairly known, it has to be ultrasound and not your anterior seg measurement,
Right.
correct?
Correct.
If you're audited, how do they know the difference? If you just have pachymetry written down?
Yeah. And the answer is they don't. Unless you put it down, they don't. Now they can, if you're doing a ton of pachymetry and you get audited, I can literally ask you what instrument you utilize. And you would have to either tell me or fib to me. So it's a good question, Joe, because it's unlikely that would ever come up. But when it does, again, you're going to get stung. So again, it's just all about just do it the right way. All right, so what do the preferred practice patterns say? Well, according to the American Academy of Ophthalmology, they now list this as a weak risk factor for the development of glaucoma, if at all. That's in quote, that's in parentheses. And even if you still believe, literally by the study, it really only relates to ocular hypertensive. So believe me, I'm not telling you to stop doing central corneal thickness. I would encourage you to read up on some of the more modern literature related to this and see if it's really of enough value to you that when your pachymeter, goes south, well, you can use pachymetry for many other things. But you really have to think about whether it's worth the investment for the questionable, I'll just put it that way, validity of its finding as a risk factor for glaucoma. All right. A lot of other experts, I don't even put myself in the category as an expert in glaucoma. But when I look to some of these people in the WGA, I mean, it's just over and over and over and over and over. They're saying that basically that hypothesis was incorrect. We're actually seeing that in some of proposed medical directives as well, making a very limiting application of corneal thickness to glaucoma. And as we saw in NSG, basically limiting it only to a diagnosis of primary open angle glaucoma, which again means when you make that diagnosis, make sure that you are classifying your glaucoma correctly and understanding that that means a glaucoma with significant elevation of intraocular pressure, not people that are coming in with 16, 18, 19 pressures. All right, ganioscopy. Probably one of the most underutilized tools in all of glaucoma. I don't know if I say it later, the concept of standard of care gets kicked around way too much. There's very little standard of care, to be honest with you. Most of that's determined in courts of law, but ganioscopy is about as close as you can get to standard of care in glaucoma. I mean, it is the defining factor that differentiates open and narrow angle glaucoma. It's an essential component of the evaluation. And I always say, dust that thing off and get to using it, because it really has nothing to do, to be honest, with whether or not the angle's open or not. Your Von Herrick measurement with your slit lamp tells you that with a very high degree of assurity. It's the only instrument we've got, though, that can go look at the trabeculum and say, this thing's clogged up, this thing's abnormal, and that's the real necessity of ganioscopy. So it does require interpretation report. You see that it says unilateral or bilateral. When you see that designation, that means that the fee you get paid whether you did one eye or two eyes, it doesn't matter. So again, not a high reimbursing code. What is anymore? We shouldn't be basing necessity on what we get paid for it anyway. But I think it's an essential component to glaucoma management. We definitely have payment policies that state that you may not substitute anterior segment OCT for ganioscopy, and the actual carrier that says that comes right out of Florida, where Joe's sitting right now, which is First Coast. So in their billing directives, it states that you may not substitute. Again, how would they know? Only if they actually made you tell them. But I will say that one audit we did, they basically stung themselves, because in a series of ganioscopy interpretation reports, we kept seeing angle open at 41.7 degrees, angle open at 36.9 degrees. No one's that good with a gonio lens. So basically sold themselves down the river. But again, just do it the right way and you don't have to worry about any of this stuff. Standard of care I just talked about. This is, like I said, as close to standard of care as you can get, and far, far underutilized from what I've seen in auditing a lot of glaucoma charts. All right, so visual fields. Now, I didn't talk about level 1, level 2, level 3, because the bottom line is we're almost always in glaucoma interested in a full threshold visual field. So I'm just limiting tonight to the full threshold visual field, 92083. Another unilateral bilateral test, one eye or both eyes, doesn't matter. Must do interpretation report. Very good idea to put what testing protocol you actually did. It helps support the fact that you're billing a level 3 visual field without question at all. So I would definitely put that down as well. National government is the one I refer to for payment directive. They have what's called an L and an A, and I put both those down for a reason. The L payment directive is the payment directive. So it's where you go to find out what diagnosis will this pay for. Is this unilateral or bilateral? What's our indication for level 2 tests in glaucoma? All these kinds of protocol type things are going to be in the payment directive. A is the billing directive. So it's the coding directive. So it's where it gets into the nitty gritty of what do we want you to document? What diagnosis codes will we pay for? Things like that. Now, there's not always an L and an A payment directive, but when there is an A, don't overlook it, because that's where a lot of the documentation rules come from. This is a test that still reimburses well, and heavens help us, it should. It's a very difficult test. The subjective nature of it, as I said, a lot of times you just want to throw the thing in the dumpster, but it's an essential component of glaucoma management. Now, they make the statement, is I hear a lot about how many visual fields can I do? The days of where we were seeing a lot of frequency limitations we're seeing less of that. We're actually seeing more of the payment directives saying, you as a physician need to determine really how many of these you need to do. And in visual field, they make a very broad stroke, which says, look, you need to do these based on what you're finding. So we're not going to tell you 1 visual field a year for moderate glaucoma, 2 a year for more severe, etc. Those kinds of payment policies tend to be going away over time, and they should. Those are things that we should be able to decide in our head based on the need of the patient. So the other thing that comes up here is, does it matter if I have a Humphrey visual field or a matrix or an octopus? And the answer is no. And this is true of most every CPT code out there. Your payment directives almost never, with some exception, actually one in particular, but with very limited exceptions, state that we will pay for this instrument and not this instrument. They don't go there. So whatever visual field you're using, based on what you feel gives you the right information, most appropriate information for your patient, as long as it does a full threshold visual field, you get paid the same as anyone else out there.
Joe, if you got a second, there are a couple of questions that came in. Do you mind?
Not at all.
Question comes, will they pay for repeat visual field if inaccurate when the patient takes it the first time? I know what my answer is, but please go ahead.
Well, there's no hardcore answer. I'll just tell you. I can tell you from a, when you go to the studies and they say, okay, what do you want? You want 3 reliable, repeatable visual fields before you make any decisions about anything. Clinically, I'm not sure that's possible. I know we did that a lot at Houston, but running a real world practice, having to do 3, and that you're not doing 3, you're going to have to run 9 to get 3 that are all repeatable and reliable in a lot of cases. So it's like, the question is, can I bill for all of those visual fields? And the answer is no. But how many can I bill? And the answer is vague on that. I have, in auditing circles, I've never had anyone say that they've ever stung anybody for repeating a visual field. So I don't want to put the magic number at 2, but as I said, I've never had any issue with that. But to say that we're always going to get paid every time we want to do one, that's probably not going to fly. What was your answer, Joe?
Well, first off, they use the term inaccurate or unreliable. We never want to use that term because that will bust us. So the second one should be payable if the first one is denied. So we probably want to say low information. I would probably say that if you repeat that one in 3 months at the next follow-up, I think that's, from a glaucoma practitioner standpoint, I think that is safe, and I would support it. The studies have shown, and the expert cognoscenti have said, in order to see what type of glaucoma you have in terms of fast progressor or slow progressor, you need 6 visual fields in the first 2 years. So Joe, when you say 3, you're talking, 3 a year. That is actually probably good care.
Yeah. And again, I think we're talking along the same kinds of guidelines. 2, 3, in some cases more. From the beginning, you said the right thing, though. If you're going to run more than a visual field or 2, your documentation has to show why it was necessary to do that. And, doing 2, 3, 4, I think it's valid. But you start getting into a bunch of visual fields on everybody every year. At a minimum, you're going to get audited because the metrics, you'll just pop up like a firecracker. And I just think it's going to be very difficult to justify 7, 8, 9, visual fields on every patient that you have. Don't think it's going to fly.
Joe, do any of these audit guidelines apply to the 9.2 codes? That was a question.
Oh, absolutely. That's why I showed you the fact that we're getting audited specifically on the comprehensive ophthalmological code, because we way overbill that code.
And somebody also mentioned they knew somebody who used a different code for pachymetry. Optical pachymetry is like a code that they feel they saw somebody use rather than ultrasound, using it for better reimbursement. Any input on that?
No.
And can you bill for macular OCT GCA to document progression and central vision decline?
Oh, good one. Well, we hadn't got the OCTs yet, so I'm going to cover that. So,
all right, so we can table that for now, I guess.
Yeah, that one's going to come up for sure. Good question.
Very good.
Very good question. We'll get there on that one. All right. Bottom line on visual fields, obviously it's essential. Like them or not, got to do them. Got to do a bunch of them. Difficult to interpret. Difficult for the patient. Before you start griping at your patient too terribly much, you need to sit behind one yourself. It's not the easiest thing to do. It's not the easiest thing to pay attention. I used to make all my students sit there and do them all the time, just so they would be empathetic with what their patients are going through. But it's not an easy test. Not an easy test. All right. So here we go with OCTs. So we have two of them. I'll talk about them separately. The first one, obviously, this is the optic nerve evaluation. Again, a unilateral, bilateral, must have interpretation report. There's national government is still the one that kind of has most of these glaucoma policies out there. And there's not a lot of limitation on this. I'm just going to tell you. This one, you will find language that says, we would not expect you to do more than a couple of these a year. Now, two things about that. Number one, I would pretty much agree. In most cases, I wouldn't see why you would, but understand the way they phrase it is in most cases. So don't interpret that to mean you have 2 shots and that's it. Just understand that if you start doing 3 or 4, your documentation is going to have to very much define the necessity of deviating from that 1 or 2 a year. And in some cases that would be appropriate. In most cases, I will contend it's a hard sell. Now, any of y'all that have been around for a while know that when OCTs first came out, the reimbursement was north of $100 per eye. Now that was in the earliest days of OCT. We've come a long way from that to $40 for both eyes. And I just interject this as a point that the market will always self-correct itself. So when new technology comes out, if everybody jumps on the bandwagon and starts doing tons of these tests, the market will adjust and the reimbursement will go down. And that's exactly what's happened with OCTs. It's not that the instruments got less expensive. It's not that the data is any easier to interpret. It's simply a matter of dollars. And so they're going to cut down reimbursement when things are done at a very, very high level. Doesn't mean we shouldn't do them. Just understand that's why the reimbursement goes down. So some other general concepts. The policy now states, and it used to not, says that we can use optic nerve analysis through all levels of glaucoma. Now, Joe will tell you just like me, when you get to end-stage glaucoma, there's not enough nerve fiber layer left for the OCT to even analyze. So running OCTs on the peripapillary nerve bundle on someone with 3-degree central fields is totally a complete waste of time. There's nothing there. We will talk about.
Joe. Yeah, Joe, the phrase I've always used is, it's like checking the pulse on a decapitated person to see if they're dead.
Yeah, that's about as good as you can put it, but that's exactly what you're doing. I was trying to
feel free to use it.
Yeah, I was trying to actually be nice. All right, so we talked about the OCT and fundus photo. It's not applicable. It's a national edit. But again, why bother? You're seeing your glaucoma patients a ton. You got plenty of time to do all the tests that you need. Now, again, this is the one that says no more than 2 would be considered necessary. And so that doesn't mean you can't. It just means you must document when you're doing more than kind of what they're looking for. All right. Everyone says these are essential, kind of. But it's interesting that the Academy and the WJ both kind of pick their words a little bit, and they all say it's supplemental too. So we're still addressing the need for subjective evaluation of the optic nerve. Now, would I say that at some point they're going to be better than us? Maybe. They maybe already be there. But the payment policies still want you to subjectively look at the optic nerve. And the Academy even makes an interesting statement that they consider it an adjunct to visual field. I totally get that, because in the management of glaucoma, especially at a progression level, what we're trying to do is prevent vision loss. We're not trying to prevent their, their mean thickness from going from 38 to 35. We're trying to prevent them losing vision. And that's what the visual field measures. The OCT really doesn't measure loss of vision. But I put them together. There's a payment policy in review right now and this is how far they're going to take it, that says that once you have a moderate level of glaucoma, that they will no longer pay for OCTs, because really all you need is a visual field at that point. You can argue that one up and down. Now that's bar talk, but I certainly see where they're going with it. Now, I would also say that we subjectively way overanalyze OCTs. They're very nice instruments. They're very accurate, but they're not perfect by any stretch whatsoever. I know Joe knows Danica Morelli, and many of y'all know Danica really well. Kind of the person who I think first started doing the red-green lectures, showing that these things can be just as wrong as the day is long. So you can't just totally rely on them, just like you can't totally rely on anything for glaucoma. It has to be big picture. So what about the retinal OCT, which really what we're talking about here is GCC. So we're measuring the papillomacular bundle, which for years glaucoma experts have said is very important, if not the origin of all damage. And people believe different things. But this is kind of our first idea at being able to say what's going on in the papillomacular bundle related to glaucoma. This is where almost every payment policy on the planet is wrong, because they all say you cannot bill this code for glaucoma. As a matter of fact, I don't know of any Medicare carrier that allows it. There are some medical payers who will pay for it, but they're just not there. They're not thinking. I don't know what's wrong with them, but I would consider it to be invaluable information. And so in that case, I feel like I need the test, and this would be something that if their insurance doesn't pay, the patient would need to pay. So that's the answer to the question that came up earlier. Valid, I believe so, at 150%. Payment directives don't agree right now, and maybe they'll change over time, but that's where we are right now. The Academy and the WGA just talk about that it's all really nice, but they're not strongly coming out in favor of it at this point. So scientific world is there, the payment world is not there yet. All right, photography. This is a bilateral code, another bilateral code. So by definition of a bilateral code, if you only photograph one eye, you're supposed to cut your fee in half. Now that's a very unknown thing and most people don't do it. But again, in an audit, you will be asked to give half the money back. There's lots of fundus photography payment directors. This is one that actually has a national, so CMS has a national payment directive, and it says several things. It says, number one, it's not medically necessary to take a picture of nothing. I'm paraphrasing. Number two, it's not necessary to take a picture of the same thing over and over. In other words, we should be documenting change. When you evaluate your glaucoma patient and you say, optic nerve, no change from last visit, you don't have medical necessity for another photo. You say, well, I'm documenting nothing's there. You just documented it in your record that's nothing there. You don't need a picture to back that up. So we're documenting abnormalities and we're documenting change over time. Now, I won't get into the whole diabetic thing, but for the most part, that rule also applies there, although we see some isolated payers saying that they will pay for a fundus photo of a basically normal patient with diabetes, but that's not the point of this lecture. Okay, let's not talk about extended ophthalmoscopy, kind of on its way out. But the payment directives do say one thing, and that is extended ophthalmoscopy in light of a photo is basically meaningless. In other words, if you have a camera, take the picture because it's far more valuable than your, 5x7 card. So photography is pretty much the most over and underutilized test in optometry. And it's because of those two factors I told you. The Academy actually is moving to a point where they're saying, we're not sure that fundus photos are going to be very valuable in the future because we gain so much more information from OCTs than just what the photo shows. Now, again, that's not policy at this point, but it wouldn't surprise me if we're starting to move in that direction. All right, let's get into the more obscure things that we can cover quite quickly because all of them have pretty much the same answer. You're not going to get paid. Visual evoked potentials, there's a code for it. You can look almost every payer directive, whether it be Medicare or medical policies. No one's going to pay for this. And this one has that same history of used to be paid a fortune until these things started being done left and right, and the reimbursement dropped dramatically. But you're never going to find a payer that pays for this. Now, again, doesn't mean you shouldn't do it. If you believe in this data, then run the tests, but your patient's going to have to pay for this one for sure. Pretty much everybody out there is not jumping on the VEP bandwagon. Now, ERG is a little different story. Although right now about the only ERG you can get paid for is the pattern ERG, and that's going to be a level 3 CPT, which means an investigational code. So it has a code and it actually has a fee, but it's not a real CPT code. It's not across the board agreed on as a valuable test. So some Medicare carriers will pay for it. Novitas in my area does. Some medical payers will pay for it. You're just gonna have to know what your payers pay for here. And again, if you believe in ERG technology for glaucoma, run it. But this is another one that then in many, many cases is gonna come out of your patient's pocketbook. Everyone's pretty silent on this, but honestly, the history of ERG studies in glaucoma go back decades and decades. And there's just tons of data to support this. I mean, it's literally a objective visual field, if you want to think of it that way. Someday they're going to come out with a wide field ERG for glaucoma. As a matter of fact, I've heard it's in development. And I think that's going to be somewhat of a game changer. Color vision. Oh yeah, there's studies you can find that say that advanced color vision analysis shows early defects in glaucoma. Absolutely, it has a code. It's going to be just like the visual evoked potential. Do it if you want to. No one's going to pay for it. No one supports it for the most part. But if you believe in that technology based on your studies, run the test. This is one the patient's going to pay for sure. All right. That's the end of glaucoma, and we really switch gears dramatically at this point to talk about inducement. But Joe, I think we have a polling question in there.
All right, I'll do a polling question for you. I think we're in polling number 3.
So as a rule, which of the following would not be considered medically necessary for follow-up of a glaucoma patient or a glaucoma suspect? So in a routine situation, which would you not think this would be the test that would be most likely for you to run on a repeat basis?
So while that's coming in, we'll look at a couple questions, Joe.
Yep.
You would use a code 92500. Do you mean 92050?
Yes, typo.
Okay. Please offer recommendations 99 versus 92 codes in glaucoma visits.
So this is opinion, but I'll base it on 2 things. Number one, the reimbursement. Well, let's do that one second. I believe the 99,000 codes are more applicable for most medical care. The ophthalmological codes are kind of neat, and it gets into a whole coding lecture, but they're very restrictive because to justify using them, you have to check off lists. You have to check off that I did all these things, but I had to check them off that it was medically necessary that I did each one of these components. And if it was not, I can't check them off, and therefore I cannot use the code. That is exactly why we have this overutilization of the comprehensive ophthalmological code, because I can't check off it was necessary for me to do a fundus evaluation for someone with an itchy eyelid. it's going to be difficult for me to justify doing a binocular assessment for someone with glaucoma. Those don't go hand in hand. So I believe, number one, the evaluation management codes are more applicable to medical care. Number two, in most cases, they reimburse higher. And number three, with the 2021 changes, if you really haven't looked at those and familiarized yourself, they have become far easier to analyze and come up with the right code. And it opened the door for higher legal, ethical application of the higher levels of the EM codes based on the new standards of how we pick the right level. So I can summarize that with just saying I would prefer the 99,000s in most situations.
Joe, why is the DME overutilization so high for optometry?
Because of one thing and one thing only, and that is they do audits of this, and to be legally under the DME system, you have to have a big checklist of things in your office. It's things like warranties and instructions on how to use your glasses and all this stuff. And when they audit, they find that we don't have those. The wheelchair people know all about these checklists and things, but optometry, it's just not something that's talked about. So despite the fact, the wheelchair people are probably the most abusive out there, as far as just percentage wise in the audit world, optometry gets stung because they don't have the right documentation.
Now, can you say in your exam that you're not sure if there are any changes in the optic nerve? You want to look at a photo for subtle changes? Is that legitimate?
I would say look to your state law. So in two cases, number one, in Medicare and according to your state law, that's where you have to look. Medicare in the national policy actually has a code that says you may not substitute a photo for a subjective analysis of the optic nerve or subject analysis of anything. You can't substitute a photo for subjective evaluation. Many state boards have exactly the same language, and many other payors have the same language, VSP being one of them. So there's a lot of reasons that you can't see. Photos are not diagnostic instruments. They're documentary instruments. They document what you already knew, not what. Now, that could all change over time. Believe me, the studies are out that show that evaluation of photo will help you pick up things that you missed. I don't care how good you are, but the reimbursement we're right now ain't going there. So be very careful with that.
Joe, going back to the optical pachymetry, it's 92499 for optical pack. Do you have an opinion on that or not really?
That's why I didn't even address it, because what that is the unlisted diagnosis code, which means it's not a code. It's not a code for optical pachymetry. It's the unlisted, which means we don't have a code for this, so you bill it under the unlisted code. That's a really good way to get audited. Now you may win that audit, you may not, but that's a really good way to get audited, is to use the unlisted diagnostic code. It's a generic catch-all.
Joe, if Medicare does not pay and the patient self-pays, how many ABNs does a patient sign and when do they sign?
They have to sign the ABN before the service is delivered. And ABNs are collected on situations where normally a payer would pay for the service, but in this particular case, they will not. So if you're talking, it's like a lot of people get a patient to sign an ABN for a refraction, which is a non-covered service. Actually, if you read the CMS manual, it says the patient cannot sign the ABN because this is a non-covered service and the patient has no binding. You can have them sign all you want to. There's nothing binding them to pay for that unless they've agreed to it outside the ABN. But bottom line is you always want to collect an ABN before the service is rendered, not after.
And can you clarify the difference between a 92002 and 92004?
Between what now? So 92004 is a new patient and a comprehensive evaluation with an 11-point checklist. A 92002 is an intermediate, which is interesting because there's no low code, but that's the intermediate ophthalmological. And there's only literally 3 things you have to do to justify that code. You have to take a history, you have to do general medical observation, and you have to evaluate the external eye and adnexa. And that's another reason why, you know, that sounds more like something you do for the patient with the itchy eyelid as opposed to somebody who has glaucoma.
Mhm. And just to add in there for our Florida folk, if you're billing a 92004 comprehensive, there's a series of tests that must be done per our Practice Act. And if there's a complaint filed against you and you're missing something, you're going to be found in violation. That's our jurisprudence lecture. All right, we can see that the results, you know, the majority of people here said both B and D. Joe?
Yeah, that'd be correct. So again, you can't predict whether you would need a fundus photo until you've looked at something and determined it needs to be documented. So you can't predict there's something going to be wrong that needs a photo, because you're going to look at it and then you take a photo to document. That's totally different than an OCT.
All right, Joe, I'm going to let you go ahead and we're going to
Okay.
move on to inducement.
Yeah, the last thing I'll say is we have that same kind of law in Texas, but it relates to the routine analysis of the eye with optical prescriptions. It really doesn't relate to a glaucoma analysis.
Mhm.
That's a whole nother. Okay, so inducement. We're gonna go through this pretty fast, but these are topics you really need to understand what's going on. And most people listening to this have no idea this is happening and why it's very pertinent that we talk about it. So let's talk about the world of cataract co-management. Why is it such a mess? And why is the Inspector General have a national investigation going on the relationship between OD and optometrists and ophthalmologists? Now, this has nothing to do with opinions or egos or making money at all. It's simply that there are facts of law associated with this. And these facts of law have been in existence for 3 decades. And it's kind of like the coding thing. The laws are there. They're just now going to go look at them. And I'll tell you why they're looking at them. So the first thing is co-management. So co-management's been around for a long time. And it usually has more application in hospitals. That's not what we're talking about. What we're talking about is co-management of cataract surgery. And for you, those that don't know, we can thank 2 guys, Paula Jamian and Bill Cuthbertson, who's gone on. Not Paul, he's still around. They're the ones that literally went to CMS and said, look, we can do the post-operative care. We should be able to do the post-operative. We should get paid for the post-operative care. And we carved out the 54-55 co-management system. That's where it all came from, what now, almost 40 years ago. So there are 2 main sources of the laws, the facts surrounding the proper way to bill and code for co-management services. One comes from CMS and one comes from the American Academy of Ophthalmology. Now, we're not under the protocols of the American Academy of Ophthalmology, but we are working with someone who is, so inadvertently, we're kind of under that system as well. So there it is. Everybody read that real fast and we're done. So that is not going to happen. So let's break it down. Let me tell you what it says. So there are several key concepts here. Number 1, it's the surgeon who decides if co-management happens or not. Now, that's why I say this isn't about egos. They are the ones that are what we call transferring the care. The word co-management is a total misnomer. There is nothing co going on here. When you receive the patient post-operatively, the care has been transferred to you. You assume total obligation for the care at that point. And that's why they call it literally the transfer of care. Now they say we expect this to be rare, which is kind of a statement I don't like very much, but that's in the statement from 30 years ago. And that may be why it was in there, because 30 or 40 years ago, I mean, optometry as a profession has progressed a long way since then. Most important thing, you can only transfer the care if it's in the patient's best interest, just like billing and coding. can only do things that if it's in the best interest of the patient. So surgeon has to decide if this is in the best interest of the patient. And we talked about transfer of care. So what does that mean? So they literally tell us when it would be in the best interest of the patient. And I'm not going to go through every one of these. It's like the surgeon wasn't available. That's not going to happen. It's a long way. Well, sometimes in rural areas, that certainly happens. It's some surgeon that flies in and does surgery in boogies. I didn't think that still happened until I was lecturing in Wyoming, and sure enough, it happens up here all the time. It's in a healthcare shortage area. Nah, not common. Again, rural issue. Illness prevents them from coming to see the surgeon. Well, how did they see you? Don't get that one. Far away, far away. Look, here's the bottom line. There's only one reason. And the reason is that the patient wants you to. And that's the only, in most cases, legitimate reason that we get the transfer of care post-operatively. So it's only covered if the patient wants to, the surgeon says it's okay with me, and you can't make them do it because you'll withhold referrals. That's actually against the law. So don't pull that kind of stuff. So this is it right here. Here's your checkoff. So the surgeon elects to transfer the care. It has to be in writing. It has to be up to the patient to do that. And two things that are going to come up. Number one, everyone has to set their own fees. Number two, everyone has to collect their own fees. So we're going to get to where that became the big problem in just a minute. All right. So what do we know is wrong? You can't mandate it. They can't send you a check for a referral fee. They can't set your fee, and they can't collect your fee. These are all against the original rules of co-management under CMS. So that's kind of like, well, that's what's going on though. That's what's happening exactly. And that is the problem. Now, that fee that you should be setting and collecting has to be commensurate with what the medical record says you did. And that's going to be a key point in just a minute when I tell you where the investigation came from. So there it is again. Surgeon has to decide, has to be in writing. Patient says they want it. Everyone sets their own fees. Everyone collects their own fees. That's been the rules forever, despite what has been going on forever, which was totally wrong. So what happened? Well, the Academy for years petitioned CMS to say, this system thinks these are referral fees, bad stuff going on. CMS investigated and actually said, yeah, we agree with you. We think in most cases it's based on economic consideration rather than clinical appropriateness, but we're not going to do anything about it. And that was a decade ago. And nothing happened until the public blew the whistle on this. And so the public went to CMS and said, this is not right. Things are going on here that you need to know about. And CMS turned this over to the Department of Justice in 2018, and the 4-site investigation started. Now, these are the 4 sites. We don't know if there's going to be more sites. There are a bunch of MDs involved with this. There are hundreds of ODs involved with this, because this is actually the notification that's, and I hope nobody on this webinar has seen this letter, but this is a 21-page letter asking you for medical records. You're going to be deposed. It's a big old mess. So you're thinking, well, why is the OD involved with this? Because we are considered to be induced to do this. Now, I'll get there in a minute. So here's the deal. It's not about co-management. And you're like, well, why are you talking about co-management then? So let's explain what really happened. So the law that's being violated is something called the anti-kickback statute, which is the law that says you can't induce a doctor to refer to another doctor in any way, shape, form, or fashion. Liberally interpreted, can't do it. So where's the inducement? Well, it's anything. It's anything of value between those two doctors. It can be money, services, meals. We'll talk about free CE in a minute. They don't have to prove that it induced you to do this. Like, really? I went and got a steak. That's going to make me send all my patients to you. Doesn't matter. The law is the law. Why are ODs involved? Because under AKS, the person inducing and the one being induced are equally guilty under the law. Now, it doesn't work that way typically, but we are. Penalties, felony criminal conviction. So these are $50,000 and up to 5 years in jail, maximum penalty for violating the anti-kickback statute. It's like, okay, well, what in the heck's going on here? What could be considered inducement? Well, all these things, but what really made this come to light was this one I just highlighted. And it all has to do with what? It's premium IOLs. So it's when the money started shifting around with premium IOLs that the public went, I don't know what's going on here, but you're telling me I'm going to go back and you're going to pay him to take care of me, or I'm literally, we've had people, one of the whistleblowers was actually told to take the check to the OD. The bottom line is the public's going, why are doctors exchanging money? And that's what started the whole thing. So very important to remember that when you charge a patient for something, the validity of that charge has to be documented in the medical record based on medical necessity. So where is the additional fee coming for management of premium IOL patients? Because the money is the same. And here's the misconception. It's like, but he's getting she's getting $4,000 an eye more because it's a premium IOL. That is 150% totally a material fee. It has nothing to do with the service component. The service component of postoperative care is no different according to the rules for one versus the other. Now, before you get all upset, I'm going to tell you how you can charge for premium IOLs in a little bit, but you have to do it the right way. So premium IOLs are no different because the surgical fee is exactly the same. And that is what postoperative care is tied to, is the surgery, not the material. Well, what's the difference? Not much, other than they gripe more, right? So I've seen stuff like this. Well, I'll get there in a second. I've seen stuff like, but I'm going to do 2 OCTs and I'm going to do a visual field and I'm going to check their contrast sensitivity. I'm going to do all this stuff. It's like, why? Because there's no documentation that people with premium IOLs get CME more than people that get standard IOLs. So why am I having to do that? Well, because their vision's screwy. Yeah, their vision's screwy because they have crappy optics in their eye. That's why their vision's screwy, not because they need an OCT. So these things are kind of made up. And I'm not disrespecting anyone's opinion here, but basically that's what's going on. So can you get paid? And the answer is yes. You have to establish a fee for postoperative care of premium IOL patients, and you have to collect that from your patient. Now, there is one other way around it that I think I talk about it in a minute, but that's the way you have to do it. And it can't be they send you a check for stuff. You can't do this. I've seen this. This is like, oh, I have to do all this extra stuff, and I have to see you 4 times more often. Because why? Because you're going to gripe about the vision more than otherwise. It's not medically necessary. But you do spend more time with them. And sometimes you're just not totally sure something could be wrong. So do we actually spend more of our time taking care of these people? Unequivocally, the answer is yes. A lot of times. Sometimes no, sometimes yes. So should I get paid for that? Yes. How do you do it? Look at everything you might be doing to a premium IOL patient postoperatively, how often you would be doing that, and establish a fee for that service. And then you have to charge that fee to the patient and collect that fee from the patient, not get a check from the ophthalmologist. So I won't go through the examples. We don't have time. But I will get to this slide. Well, I don't want to do it that way. Well, that's fine. But I'm just telling you that hundreds and hundreds of your colleagues got that letter, and they're all under investigation by the federal government for felony fraud inducement. And you have to do this the right way. So what's going to happen for all this? Okay, am I sure? Yeah, I'm sure. We're an auditor in the whole investigation. And the law is real clear on what it says. So you really have to do it this way. I think this whole thing is wrong anyway. It needs to stop. This does not happen outside of this crazy relationship between optometrists and ophthalmologists. Cardiologists and cardiovascular surgeons don't exchange checks back and forth. Doesn't work that way. Shouldn't work that way for us either. So what do we know about this so far? What's the result? The first site is in. I'll just tell you, the first site is in. The ophthalmologist has been charged with felony fraud and 5 years in federal prison. We're waiting to see what happens to the optometrists. They are not messing around with this, and you shouldn't either. All right. So, last inducement. This is everyone, if you pay attention to what people send you, I mean, my company sent this out, the AOA sent this out, and this is absolutely black and white. The Office of the Inspector General, our federal police, says free CE offered to optometrists by ophthalmologists is an inducement, same problem, same anti-kickback statute, same felony fraud inducement problem. And so what exactly did they say was a problem? If you attend a meeting sponsored by ophthalmology group or you get free CE, that's a violation of the anti-kickback statute. If they serve you a big old steak and a couple of old fashions, violation of the anti-kickback statute. Even if you attend where a vendor pays for all this, but you still get it free and the education comes from the ophthalmologist, still a violation. We don't know this last one. What if, you know, I worked for a referral group forever. I did most of the lecturing. What if Joe goes and just lectures on glaucoma, but I don't even mention who I work for? And they said, well, what's the intent really? And we may want to investigate that as well. But the others, they have blanketly said, we consider this to be inducement and we are going to start looking. So what is legal? It's legal if you pay a fair market value for CE presented to you. That's the only thing that's legal. It's legal if you pay your own meals, pay for your own drinks. That's what's legal. And a lot of your ophthalmology groups may have already heard about this and are saying, oh, we're not going to do free CE anymore. Now you have to pay $30 for your CE. That's because that's what the law says you have to do. So take home message. These agencies are all over this relationship between optometry and ophthalmology. Be very, very careful about your relationship there. So that's the end of my presentation. I think there's maybe a last polling question as well, Joe, if you want to throw it, or if you just want to
do that for you right now.
Whatever you want to do.
There's actually two polling questions.
Okay.
I'm going to go right to the last one because I think that's the closest.
Okay. So which of the following scenarios would optometrists be totally comfortable attending meetings offered by ophthalmology groups? Totally comfortable. If one of those sounds gray to you, I would not consider that to be the answer.
Now, while that's coming in, Joe, I'm gonna run a question, a hypothetical.
Yeah.
Say my group, Optometric Education Consultants, goes and gives a free meeting live.
Yeah.
Is that in violation?
No, because to be a violation, you have to have a relationship where I would be referring patients to you, or we would be referring patients back and forth. So just the provision of education is not a violation of anything. It's only in some way that would influence me to send patients to you for care. So I'll just throw in a follow-up question that I've been asked. Well, what about the OD in town who is the low vision person and they put on CE and I might be sending them low vision patients? The answer is twofold. Number one, the OEG is not investigating that, but number two, the intent is likely exactly the same. So I would be very careful about that as well. Well, I think we hit a home on that one.
Yeah, I think you got that point across very well, Joe. So do you have any last words?
No, the last words, and I think I've said this about 10 times already, is, you know, rules are rules and we can argue rules all day long. Some of them make sense, some of them don't. I think most of them do for the most part. The government may take things a little too far sometimes. I think they're doing that with this whole inducement thing, but the reason they're doing it is because the investigations prior to this have revealed a lot of bad stuff going on. And, you know, sometimes you throw, you know, they throw the baby with the bathwater out. And that's what happened with like ERGs. Instead of making good policy of when you should use an ERG with glaucoma, they just said, we're just not gonna pay for it at all. They're kind of doing that with this inducement stuff. They're just saying, look, we're not putting up with nothing. We're gonna draw a very hard line on this, and we are going to stop anything that smells of inducement. I would just say, just sit down and by yourself in front of a mirror and think about if these things I've been saying make sense. That, I mean, should we not be charging our own fees, collecting our own money? Why would you want some other doctor to be doing that for you when that's totally out of line with everything else happening in the medical world? So a lot of this stuff just makes sense, and it still just comes down to, look, let's just do things the right way, and let's do things that are best for our patient. A lot of this stuff just really falls into place if you think of it that way.
You know, a couple of questions came in. I like them. What about the webinar with an OMD? I think personally, I think that's the same thing if you're getting free credit.
Yeah, it's the
If you're
same
just getting,
thing. They
yeah,
don't,
if you're getting,
yeah, they don't address the format, only the fact that you got it for free.
Mhm. Now, if you're getting education for free and not credits, I think that's in a different spirit.
It definitely, that's a really good question. It definitely falls in the gray zone, because if you're just getting education, that's something of value, but it's not the tangible value that you got it for free so that now I can go get my license renewed. And I can do that for free instead of having to pay Joe Salka for education to get my license renewed. That's where the inducement factor comes in.
Question, does it mean you can't make any referral whatsoever to the ophthalmologist offering the free CE?
So here's my hard line answer. I wouldn't have been at the meeting that gave free CE, not based on the current state of these investigations. I just wouldn't do it. You've got tons of great sources for CE. As a matter of fact, I would encourage you get all your CE from your colleagues. This stuff like Joe and Greg put on, I mean, this is high level, good CE. You don't really need ophthalmology to educate you. So the bottom line is I wouldn't have been at the meeting to begin with. And if I didn't go to the meeting, they can't charge me with, you know, being induced